Hello, welcome to our webinar on implementing postpartum depression screening during infant well-child checks. We will be talking about options and resources for addressing logistical barriers to screening during child and teen checkup visits. My name is Tessa Wetjen, and I am a part of the Maternal and Child Health section of the Minnesota Department of Health, and I'll be leading our webinar today. I am the coordinator of our Postpartum Depression Quality Improvement Project, and with us later on our call will be Dr. Brian Lynch, a pediatrician with the Mayo Clinic, and Dr. Shannon Neale, a family practice physician with the Nicollet Clinic. These two have implemented postpartum depression screening in well-child checks, and they'll be sharing about their experiences. Today we will talk a little bit, we're going to talk a lot about the postpartum depression screening and how to implement it. If you and your practice are interested in further work on that, we will have a learning collaborative that will be starting in summer 2016, and we are still signing providers up for that project. So if you are interested in working in a learning collaborative to implement the screening process, please do contact Tessa Wetjen at the contact information provided here. So today we'll be talking a little bit about why we should implement universal postpartum depression screening and why do it in the well-child check. We'll be talking about how to plan for referrals. We will be discussing logistics that may come up and possible ways to overcome barriers. And we will hear from both Dr. Lynch and Dr. Neale about their experiences. And then we'll be taking questions and comments. So why should we screen for maternal depression in the well-child check? Well, a number of reasons, clearly, but first and foremost, that maternal depression has significant impact on both mom and baby health outcomes. It is very much the maternal or the primary caregiver mental health has a significant impact on child health, and that's why looking for it within the context of a child well-child check is appropriate. The symptoms of maternal depression and symptoms of depression, it doesn't self-resolve. Often people think we're referring to what's commonly referred to as baby blues, which is kind of deep emotions, can feel like depression and anxiety, but comes up really within those first 2 weeks after a baby's birth and does self-resolve. And that's not what we're talking about. So screening for maternal depression is done because it is something that is not likely to resolve itself quickly, and because treatment and support exists. It is something that we can help a mom and her family figure out how to deal with. And because we know our prevalence is significant and it has health equity implications. The prevalence in our state is probably similar to nationwide, which is between 10 and 15%, but our information tells us that those numbers are much higher for moms of different cultural and community groups. So what are the effects of maternal depression on the child? Untreated or existing maternal depression, the impacts on the women and the mothers are the mom is less likely to breastfeed, might exhibit poor self-care and inability to follow healthcare recommendations, and we have an increased risk of negative behaviors such as substance abuse, suicide, and the negative increased risk of future depression. On the children that mom is raising, we have evidence of the impact of sleep problems, developmental delays, specifically difficulty with language development and attachment issues. We have an increased risk of mental health issues for the child and an increased risk of failure to thrive. Minnesota has what's called the Pregnancy Risk Assessment Monitoring System. This is nationwide. Not all states participate in it, but a number do, and Minnesota is one of those. This survey asks a couple of questions to help us identify issues around maternal depression in our state. It does not say, the question is not, do you have postpartum depression, but it's a little more specific to asking mom has she been told by her provider that she has postpartum depression? Has she experienced some of these symptoms? Has it impacted her life? And so looking at those percentages, we see statewide actually a little bit lower number than we'd expect at 9.2%. But we see in our Black population and in our American Indian population statistically higher percentages. We have 14.4% and 20% among American Indians. We also see a statistically higher percentage in those who did not complete high school at a 16%. And so we do know that we have particular populations within our state that are experiencing postpartum depression at a higher rate than the average population. Another interesting information that we know is from our billing data. So the Department of Human Services does collect billing data from women who are enrolled in the Medicaid program. So for 3 years, for 2011, 12, and 13, we were able to identify how many mothers had a coding or had prescriptions or using a couple of different things, had some way of us understanding that they had a diagnosis for depression. And so we covered around 18% of our MA population for Minnesota. And we pushed a little further to ask us, of those moms who have a diagnosis that indicates postpartum depression or depression within the year after birth, how many of those moms had a code for mental health treatment, at least one? And on that, looks like our numbers are actually going down. So we had 63% in 2011, down to close to 50% in 2013. So what we're talking about here is, if you average those out, around 50% of moms who have a diagnosis were receiving any treatment. Now, we certainly know that we are likely to have a large group of moms who do not have a diagnosis and are also, therefore, not receiving treatment. So the best practice here is, instead of trying to sort of guess or identify which moms might be the ones who need treatment or need a diagnosis or a next step on maternal depression, is to just go ahead and universally screen all moms. So that's what we're asking you to do, is to universally screen all moms in well-child checks for maternal depression. And we are asking you to use a tool. There are actually 3 tools that are available within Minnesota, within MA, for the PHQ-9, or the Patient Health Questionnaire, the Edinburgh Postnatal Depression Scale, which is usually referred to as the Edinburgh or the EPDS. Also, I should mention the BEC is a tool that is eligible for billing. However, the BEC is a tool you have to pay for, and so we are not going to talk about it today. We're talking about the ones that are free. You are also welcome to use a pre-screener tool, which is a PHQ-2 instead of the PHQ-9. It is appropriate in the pediatric visit. It is not billable, so we won't spend a lot of time talking about that. Basically it's 2 of the PHQ-9 questions. The screens are most effective around 3 weeks after birth, according to a lot of the research, but we know we don't always see moms 3 weeks after birth, and that we also have moms who aren't willing to talk about depressive symptoms until they either manifest more or they've just become tired of dealing with them or not talking about them. And so we are recommending a screen at all of the well-child checks up to 6 months and up to 12 months if you're able to put it into your system at your clinic. We're going to talk more in depth about the different types of referrals, but we do recommend that everyone plan for the referrals that you may make as a result of doing the screen. For those moms who have low to no concern indicated on the screening tool, we are going to show you the maternal well-being plan, which is a tool that you can really use for a conversation with mom about how to promote and maintain positive well-being. We also have a fact sheet regarding postpartum depression and anxiety, and these are just tools that can be shared with any mom regardless of how she scores, or families regardless of how they score on a tool, in order to help sort of increase the education families are receiving about postpartum depression and about maternal mental health. For those who indicate a moderate concern on the screening tool, we do recommend that you work with the mom to make a detailed plan for the next steps, and that you do follow up within 1 week. And I want to make a caveat, or I should have said this earlier, we're not exclusively talking about moms. This postpartum, or the postpartum depression screening, we really want to think about doing it with the primary caregiver who's bringing mom to the visit. Some people in the past may not have recognized that it doesn't have to be the birth mom. If there's an adoptive moms can also experience postpartum depression, and so we want to be screening those as well. And if it isn't a case where the father or grandmother or aunt or someone else is the primary caregiver, we can certainly be screening them as well. It's the mental health and the well-being of the primary caregiver is really what we're getting at. Just to make it easier, and because most often that's mom, that's why we're going to use mom as our target for this presentation. Okay, so getting back to the referral techniques, if there is a moderate concern, we do want to create a referral plan with the mom and designate a staff or a process for which your clinic will follow up with mom within a week. And if there is a crisis situation, we do expect an appropriate crisis level response. In a unique situation with a mom with small children, and sort of there are some good questions that we'd like you to ask in that crisis situation and as you create your plan for that. So thinking about what those referrals might be for a mom with a moderate concern, there's some things to consider. What are the easy or most rational referrals within your own network? Are there, if the provider who's working with the child is a family practice provider, can they see the mom themselves? If there are mental or behavioral health options available within the clinic or within the network, would those be the first response? We're going to stress that you want to talk about who mom is willing to see. So maybe mom is more willing to see their own doctor. If not, maybe mom would be willing to talk to a family home visitor or to a therapist or a support group. There are non-medical supports, things like family home visiting, non-medical or non-health system support groups that might exist in the community. And if mom isn't willing to go to a provider, she might be willing to go to one of those. And so it's helpful to figure out what those are in your community. And really just talking to mom about what she is willing to do and take it from there. We thought, well, of course the referral is back to the primary care physician. Well, sure, but if the mom has this great relationship with her OB or her midwife, who she's just been seeing for 9 months, then maybe she should, and she'd be willing to go to them, maybe she should talk to them. It is really a conversation with mom about who is the provider that she's most willing to see. And really thinking about treatment in terms of 3 different areas of support. There are peer and community support programs. There is psychotherapy. There is cognitive behavioral therapy, and there are therapists who are really well trained in how to understand using those treatments for moms experiencing postpartum depression. And there is medication. It's important in this context of serving the child as a child provider that I think it's helpful to be aware that moms are concerned. There are some moms that are concerned about taking medication when they are breastfeeding, and it's not an irrational concern. And so if you are going to be serving mom and seeing mom and discussing medication with her, then that's a risk conversation that you'll have to have. We have found in some of our clinics who were doing referrals that moms were told that they were not allowed to continue breastfeeding on medication. And so that's a conversation that if it's possible and appropriate to have with mom about the different risks, then that's something to talk about. There are those that take the stance that the unknown, and yet it's an unknown risk, and that in weighing the risk factors, there are moms who do breastfeed on medication with an understanding of the risks, and that it's worse for the infant or the baby to have a mom with untreated maternal depression than not, and that the benefits of breastfeeding outweigh the possible risks. Those are certainly larger conversations than you may want to have in the pediatric well child check, but it's a good it's information to be aware of and to be able to have those conversations if that's what mom wants to talk about. And there are sources for your referrals and for your questions. When we think about crisis, if it is a crisis and your clinic is not prepared to handle the crisis, then we may need to call 911. You may need to call the crisis connection or the suicide prevention line. These are also numbers that are available on those the information tools regarding depression and anxiety that mom can take home in case of a crisis later. But we do want you to think ahead of time about what your crisis plan would be. And we have some referral opportunities or some places to go for questions about other referrals. United Way First Call for Help can certainly help identify options. An interesting option for providers and for families is the Mother Baby Hope Line at the HCMC Center, or at Hennepin County Medical Center. This is a warm line, not a hotline, so you'll expect a call back within 2 days, and they actually can provide support for providers as well as for moms and families. So if a provider is interested in supporting a mom in pursuing medication for mental illness or for depression while breastfeeding, this is a place a provider can ask some questions about the best medications to use for that, or any other questions providers can have about best practices and treatments. The Mother Baby Helpline is prepared to help answer those. More of a regional and community support is what the Pregnancy Postpartum Support Minnesota resource list can help you with. They can help identify support groups in the area, trainings for providers, other sort of regional activities. And they've actually recently started a new service, which they've had their helpline. Their helpline is, again, a warm line as opposed to a hotline, so you may receive a call back instead of immediately talking to someone. But they have also recently added a texting service, which is just, I think, a great option for some moms. So this is a helpline for moms or for families. The information will be provided by peer volunteers, or the response is provided by peers, and a mom can email, call, or text to the information there. So going back to some of the other resources, the maternal well-being plan is a way to talk to mom about what it means to promote maternal well-being or positive mental health for mom. So this is a modified depression action plan, and it's a tool that's been used to help people deal with depression. So this is what we tried to do is modify it a little bit because it had some expectations around how sleep and other things that are just hard to do with new babies. And so what we did is took it and put it into what we think can help support well-being for a mom. And it does talk about rest, sleep, connection with other people, healthy food, movement, of support. And it also provides mom with an opportunity to think about, how will I know if I'm not healthy, if I'm not feeling well mentally, and who would I talk to about that? And it asks some of those questions. We also have, and we have that in 7 languages. Amharic, English, Hmong, Karen, Russian, Somali, and Spanish. Also in those 7 languages is our basic information sheet about postpartum anxiety and depression. And those tools, just to highlight a little bit more about how to make that selection between the PHQ-9 or the Edinburgh, the PHQ-9 9 questions. Neither the PHQ-9 or the Edinburgh are validated in some of the languages that we have here in Minnesota, but some of them are available as translations as an unvalidated tool. And so we have this little nice grid for you. Some questions to ask and what this is a tool to help you in your practice decide which of these screeners might be the best for you. The PHQ-9 is not specifically designed for pregnant or postpartum women. The Edinburgh is. The PHQ-9 is widely used. It is used, I wouldn't say exclusively, but very widely used in the behavioral and mental health community. The Edinburgh is not. Some people will not know what the Edinburgh is. The reason why that might be helpful is if you are referring a mom with suspected depression to a mental health provider, it may be helpful to say, and her PHQ-9 score was a 12. If you say the EPDR score, they may not know what you're talking about. All 3 of these are billable within the Well Child Check, and the PHQ-9 and the Edinburgh are both free and easily accessible. And when you do look at those tools, kind of think about which tools are used in our system most often, which tools are available in the languages we need, and maybe that one or both of the tools are already available within your electronic health record or your smart test, and that's something else to consider. Another question we get a lot is, well, which of these visits should we screen at? And certainly we recommend, if you can figure out a way to get it into your schedule, to just go ahead and screen at all the visits. This is certainly it seems the most appropriate, especially for clinics where families or children are not coming in exactly on the dot for each of the visits. They may come in at 3 months or 5 months or 7 months instead of at the 2 and the 4 and the 6. And so if you're doing it at all the visits, then you don't have to worry about which visit is this. If you're only going to pick 1 or 2 to do it at, we certainly would hope for the 2 or the 4 months, or the 2 and the 4 months. Now, This also relates a little bit to, is this provider also the one seeing the mom for her postpartum visit, which is at the 6 weeks? One of the reasons for doing it in the infant well child track is that a depressed mom may not be attending her postpartum visit. If you know that they are, it's the same person seeing it, then that might be a reason to do 4 months. If your moms are not consistently attending their postpartum check, which nationally I think it's about a 66% that are, then doing the 2-month check is a really good idea. We don't want to only do the 1 week visit, and it's questionable as to whether or not you would do it at the 1 to 2 week visit anyway, just because mom is really just coming out of that newborn days and it's not really the best time to assess. Another really big problem or big question that people face is where to document. So where to document the score and the follow-up. There are many options for this. In order to bill for it, it needs to be documented in the child's encounter that a screening tool was used to screen for maternal depression. That's what you need in order to bill. So you don't even have to list, you certainly don't need to list the score the score on the screen in order to bill for it. However, now that you've screened the mom, you have a score and you may have some follow-up to do. And so that probably needs to be documented somewhere, and determining where is really up to you and your system to determine. Some people have chosen to do document everything within the child's health record. Some document within the mom's health record. If mom is not a patient within the system, or if many of the moms are not a patient in the system, then most likely you're going to have to figure out a different way to do that. And so there are a couple of different ways people have done it. Oops, I'm sorry, I'm going to go back. In addition to putting it in mom's record, another option people have used is developing a separate file. And so, like a folder on the share drive or a folder in a protected spot in which the screens are scanned into and remain there. And if you ever needed to follow up on it, you could find them there. And the follow-up and referral is tracked there, but it isn't tracked in the child's health record. And that can be another way to protect the separation of that information. Another note that we want to add is if mom's score is positive, it's important to think about how to ensure that the baby is screened for social, emotional, and development concerns at the next visits for at least the next 2 years. So if you are not already doing those screens at each of those well child checks, there's certainly new flags that you need to put into the child's medical record in some way. This is a lot of information about how to bill for it with the CPT codes. This information is found in the Minnesota Healthcare Program Provider Manual, so I'm not going to spend a lot of time on it. Just a few notes on how to differentiate between baby blues and postpartum depression. Baby blues is pretty common. It's up to 80% of new moms. It kind of is that emotional instability, crying spells. It looks like sadness and irritability and anxiety, but it does not interfere with the care for the infant. It occurs very quickly after birth in the first month, and the symptoms do resolve. This postpartum depression, as we said, again, we think is somewhere between 10 to 15% nationally. Research shows that in high-stress populations or communities experiencing a lot of stress, that can be closer to 30 to 35% of moms. Some similar signs, irritability, but also feelings of deep sadness and symptoms really very similar to a major depressive disorder, and can include thoughts of harming herself or her child. It can occur any time within the first 12 months after birth, and the symptoms will persist and do require treatment. So we want to encourage you not to forget the partners. About 10% of partners, so not the mom or the main caregiver, but the other partner, will also experience symptoms. You can ask the partner about their feelings. You can normalize and validate that it is a stressful time for partners. And partners can experience depression along with mom's experience of it. Some considerations when you make those referrals are, does mom have a primary care provider who she wants to see? And And really, again, getting back to that idea that a warm handoff is a handoff that is done quickly and that we're aware of the time, but we also talk to mom about who the right person is to make the handoff to. If that referral handoff time can be made while the mom is there in the office, even better. That would be ideal. So I want to encourage you again that if you're interested in this quality improvement project to help your practice implement this, we do have openings in the quality improvement project that will be starting in the summer of 2016. So now we're going to go ahead and hear from some of our providers who've had experience at implementing maternal depression screening. So we want to thank Dr. Lynch for being here. He's calling us from the Mayo Clinic and is going to share about his experiences. Dr. Lynch, go ahead.
Perfect. Okay. I'm a general pediatrician. I work at Mayo Clinic in Rochester, Minnesota, and we've been doing maternal depression screening since 2009. And it's been an overall outstanding experience for us. We've used the PHQ-9 mainly from convenience. We already had it in our electronic medical record. When we started this process, and it continued since then, we've always documented the results of the screen in the child's medical record. That's being reevaluated at this point, but until this point we've done that. We had our legal team here review that. We had some advantages at our clinic. One is that we had, that most clinics don't have, we had depression care coordinators on site at our clinics where we initiated this. So as a pediatrician, if concerns were identified on the PHQ-9, I could immediately refer a parent to someone on site who could then further assess them and set up follow-up. So that was nice. And that's something a lot of clinics don't have. Another advantage we have is that most of the children I take care of in my clinic, their parents are also taking care of a Mayo Clinic. So we had access to that maternal record and those contacts. So overall, the experience has been very good. We've had very few problems. Families have been very accepting. Again, there's been a few cases where a mother has had care outside of Mayo Clinic, and we've had to sign an authorization then to communicate with their provider or follow up with the mother about how they're doing and if they've had follow-up set up. There's a few rare cases like that, but most of the time, again, the follow-up would be coordinated by these depression care coordinators that we have assigned at our clinic, and that's worked very smoothly. So right now, we're reevaluating this process for kind of all the Mayo Health system, and I think with the idea of now patients having portal access to their record, and then some of the lessons learned from Tessa's project, the idea of actually putting the actual score and follow-up plan in the child's record is being questioned right now. No final decision's been made, but I get the sense that maybe our legal team will argue that we just put screen completed in their record, and then we put the results of the screen in mom's medical record. So that's kind of where we're currently at.
Thank you so much, Dr. Lynch. That was great. Next, we're going to hear from Dr. Neale. She is a family physician at the Park Nicollet Clinic.
Okay. So like Tessa said, I'm a family physician at Park Nicollet, and we rolled out postpartum depression screening throughout all of the clinics, family medicine, pediatrics, and med-peds, as well as will be in the fall of 2012. Prior to that, we had rolled out developmental and autism screening throughout all of Park Nicollet in 2010. So for us, it was kind of an easy add to get people to just do another screen. But I'll talk a little bit about how some of the challenges we had initially getting people to screen at all in 2010 when, and one of those was because we're so big, we had people doing lots of different things at all different sites, a lot of times using them incorrectly. They weren't approved screens. Some people weren't screening at all. So what we did was we actually chose the screens purposely that we told people that they needed to do. As far as the postpartum depression screen, we chose the Edinburgh because it does have a couple of questions that specifically address anxiety, and so we wanted to make sure we were capturing that. So we told people which screens to do, and then we did a lot of education. We WebExes where we talked about why we were doing this. We went out to each of the individual sites and taught nursing staff and clinicians how to score them, and talked about some of the barriers that they might have. Because every site is different, we understood that people might be having to distribute the screens differently. And so we said that that was okay as long as they use some of the methods that we recommended, such as some sites hand them out at the front desk, some the nursing gives the patients a screen in the room, some mail screens ahead of time. Some people have people arrive early to do it. In any case, the goal was that they actually just handed them out. And then we developed some queuing sheets so people remembered what they were supposed to do at each site, because once you start screening, there are a lot of different types of screens and people get confused. That's normal. We currently are screening for postpartum depression prenatally and at postpartum visits at 6 weeks, as well as at the 1 month, 2 month, and 4 month postpartum or child visits. One of the things we found was that a follow-up plan, if there's a positive screen, is really important to have in place. That's one of the barriers that people don't want to do screening, is they're worried if they have a positive, what do they do? So one thing, our mental health department here, we've been really fortunate. They've been very supportive. They started a few years ago having all of the Edinburgh screens, whether they were positive or negative, sent to a central area in mental health after they were done. And then the positives are all called by somebody in mental health and to make sure that people are being followed up with quickly. That doesn't mean that people aren't being followed up with at the office immediately either. It's just sort of a safety net for us and also for the providers as well. As far as documentation goes, our legal department was very uncomfortable with us putting scores in the baby's chart. So we came up with this system where if the mother was not a Park Nicollet patient, that the screen for the baby would go into this shadow file that we would just keep indefinitely. So if at some point it was needed to be referred to for whatever reason, it could be accessed. If the mom is a Park Nicollet patient, that baby screen is just sent to the mom's chart. And then obviously if it's the mom being screened, then that's the easy one. But the hard one is always the babies. And so we also came up with some wording that if there was a positive screen, that we could at least know for the next visit that there was an issue. So something like the Edinburgh was completed and a referral was made, versus if it was normal, Edinburgh was completed and there were no concerns that arose. So this actually is being looked at again, though. Apparently our legal department is having a change of heart and thinking that maybe we actually can put some more documentation in the baby's chart. So I think we're going the opposite way as that Mayo is right now. But again, I don't know what's going to come with that. Usually these things take a year or so to get all hashed out. But currently that process I just said is what we're doing.
Thank you so much. Now we're going to go to our questions. We have some that have come in. Dr. Lynch from the Mayo Clinic, can you clarify for us who is performing the screening?
Yeah, so here's Dr. Lynch, and here the care coordinators are registered nurses, but I think after having experience with care coordinators over the past 10 years, they wouldn't have to be for a lot of these things. They could be social workers. There could be different staff with different training who could successfully sort of do this follow-up and work. But here, we've used registered nurses who've got special training with depression management.
Thank you. Dr. Rich, can you clarify for us who is doing the follow-up?
So the tool is actually handed out by our front desk, and then it's completed by the families. The nursing staff make sure it's completed before I, as a provider, come into the room. And then I'd be the one who does the initial scoring and deciding what the plan would be. Again, if it's passed and there aren't significant concerns, we would discuss that there, and there wouldn't be any follow-up. If they did not pass the screen, that's when we would talk about the follow-up plan. And again, in most cases at Mayo, that mother is cared for at Mayo, and so either they're getting depression therapy right now, or I'd refer them to these RN depression care coordinators who would then come in, take some time to assess the situation, try to make sure, does a referral need to be made today, or does any more action need to be done? And then there's a minority of cases where the mother was not cared for at Mayo, where I could not involve those depression care coordinators, and then I would be making that plan with the mothers.
Great, thank you. Another question that I would love to have both Dr. Neale and Dr. Lynch answer is if you would talk to us a little bit about how much time this added to your visits, and I guess overall what you would say the benefits are of incorporating these screenings into all of your visits, sort of in relation to the cost of time and energy or things like that. So what would you say to other providers about that?
Sure. Overall, the biggest time crunch of doing screening is actually having people do the screens. So as far as what it adds to my face time with the patient, as long as I have the screens done when I go in, it makes my visit so much better. And I think universally providers would say that because it gets all of the concerns out there at the beginning. Probably, maybe not all, but 95% of them. So it decreases the by the ways, and you think everything's great, and then they drop something at the end. So, but the challenge is figuring out how to get the screens done before you actually go in the room. So we ask people to come in 15 minutes early. Again, like I said, every site does it different. Some sites send out the screens ahead of time. We're waiting for the day that we can have them in my chart and people can do them. But there's a lot of problems with some of the screens with licensing. Not so much for sure with the PHQ-9 and the Edinburgh, but we're just not there yet. So that's really the biggest barrier, but we have so many different sites with different capabilities of people being able to turn them in. Like the site that I work at, we probably get, if we were to mail these out, we probably only get 40% of them back just because of the patient population. And then there's other sites that they get 100% of them back. So I think you have to look at who you see in your clinic as far as how you decide how you're going to distribute them.
I echo that experience at Mayo Clinic. I think it helps the efficiency of my visits to actually have the screen. I think before we had the screen, I spent time trying to ask some of these questions. I didn't do it in an organized way, and I had to always remember to do that. And now I come in, and 95% of the time I'd say the screen is completely completed. I can review it. If there's minor concerns, it's discussion points right there, and we can add on to maybe the mother's very tired, which is not unexpected, and we can talk about that. So I find the tool to be very helpful. In the few cases where it is not done, usually it can be completed quick enough, maybe during my exam of the infant or other times, that I also don't think that affects the flow. So I think overall it's been time even. We've actually done studies at Mayo Clinic, not with this screen, but with the developmental screen and social emotional screens, and we found too that overall it's been very minor, the amount of increase in time. Just, a couple minutes at most overall. In that, instead of reviewing these questions, you have them done by the family before the visit. Obviously, every clinic has to assess how to do it, and I think with a lot of the new technology, they could need to be done by portal prior to the visit. But then there's a lot of issues with that. What about the timing? What if a mother completes this and the suicidal to complete this 2 weeks before the visit? You have that and you didn't act on it. So there's new questions that come up. They'll come with that also. But I think every clinic has to assess it individually based upon the technology they have and the patient population that they have.
Thank you so much. Now we're going to go ahead and try to answer some of the questions that have come in from our participants. So the first question is, do the health plans pay for screenings? Sort of, is our answer. So they definitely should be paying for the maternal depression screening in a well child check for a well-child check for a baby under 12 months old for a mom who is enrolled in Medicaid. It is not consistent yet with private pay health insurance plans. So, for example, one of our clinics was screening all their moms, and they did have a couple of moms receive a bill for it. Those actually ended up all being people who were employees of the clinic. So it was people who were on a private pay health insurance that was owned by the clinic system. Anyway, they're working on it. So the private pay should be covering it. Whether or not they're set up to cover it yet is not, it depends on your area and where you are. And so I would say that that is one of the reasons why it isn't consistently being billed for. Sort of more information on that is that when we look at our billing data, we're only seeing it in I think less than 3% of our of the well child checks that are billed under 12 months. And we think that the screening is happening more than that, but we just don't have people billing for it consistently yet. So it should be paid for. Whether or not it is, it would really depend on the systems that the health plans in your community. The next question is, we are an independent pediatric practice. If we need to make a referral for mom, do we need to automatically refer her back to the prenatal provider or her primary care physician? No, this will depend a lot on the mom and also on mom's insurance. So some insurance plans, I think the majority of them actually will allow mom to go directly to a therapist or to mental or behavioral health without a referral. Some will want her to have a referral. There's actually, the majority of plans have a phone number that the mom can call to ask what the mental health referral should be. But really, when we think about giving the referral to mom, we should really focus on what mom is most likely to follow through with. And so if that is her own prenatal provider or primary care physician, then absolutely. If it is someone else, then someone else. But that referral, you're going to be calling and helping to make it a warm handoff referral, but it is what the mom is choosing. And so that, no, it doesn't have to automatically be back to her primary care physician. And our last question that's come in is, can we explain the rationale for postpartum depression screening at a well child check versus at their 6-week postpartum visit? I can answer that. We are not saying do it at the well child check instead of their postpartum visit. We are certainly recommending also doing a postpartum depression screen at the 6-week postpartum visit. We are adding it in the well child checks because of a couple of things that we've mentioned. Because moms with depression may be less likely to actually attend their postpartum visit, because in general, we have a much better turnout for the well child check than we do for the postpartum visit, and because moms have generally been shown to have a different rate. There's a wide variety in the rate of when mom is willing to start talking about her feelings of depression or anxiety. So there aren't actually, Dr. Lynch was part of a study that looked at returns on a 2-month screen versus a 4-month screen. There are moms who will screen positive at 4 months who would not screen positive at 2 months because they weren't willing to talk about it yet, or the symptoms itself hadn't become to such a case that they really felt like it was interrupting their life or their ability to care well for themselves and their child. And so there are moms who won't talk about that until later on in the experience of postpartum depression, and so that's why we're recommending doing it at the well child checks. And then really getting back to the fact that this is an issue for well child, for baby health outcomes, is the status of mom's mental health. And so that's why we're recommending it at those visits and not, it isn't an or question, which one, it's to do it at both, the 6-week postpartum visit and the well child checks. We want to thank everybody for your time in listening to our webinar and participating in our webinar today. I'd like to especially thank Dr. Lynch and Dr. Neale for all their time on this work, both in their own practices and spreading this within their systems, but also in supporting other providers across our state in implementing universal postpartum depression screening for moms within those well child checks. So thank you so much. Thank you for your time. If you do have any questions, or if you would like information about the Postpartum Depression Implementation Learning Collaborative, or any other materials. We certainly have a lot of things online, and we are also welcome your contacts and emails. You see on the screen my email and contact on our website, and then also if you have any questions related to child and teen checkups, please feel free to email or call them as well. Thank you so much for your time, and good luck with implementing universal postpartum depression screening.